saying in Hebrew, which I'm not sure I'm going to say correctly, but Mikol Talmidai Lamanti, something like that. Someone wants to correct me. So in reality, I think. Okay, so I'm going to talk, and I apologize that I have to start early, but I have a brief to go to, unexpected. So I'm going to talk about metatarsalgia, and basically the topics that I'm going to cover are, first I'm going to talk about the definition, etiology and predisposing factors. I'm going to talk about Morton's neuroma, I'll explain what that is, and then I'm going to divide the talk into osseous abnormalities, such as stress fractures, stress reaction, Freiberg's, and subchondral, and then I'm going to talk about soft tissue, Morton neuroma, plantar plate, and callus. Actually, I'm probably not cover much callus. So when we talk about metatarsalgia, specifically when we talk about this lecture, but in general, when people talk about the metatarsalgia, they talk about pain at the ball of the foot, and usually of what we call the lesser toes, the last or the lateral 4 toes. So we usually exclude the first toe. And the definition of metatarsalgia is basically it's a common overuse injury. It is a non-specific pain at the ball of the foot. As I said before, the metatarsalgial joint. It presents with progressive discomfort. And etiologies are multiple etiologies. We can think about high-impact sports, track, field runners, tennis, but in reality, all these sports-related activities, but in reality, active individuals in daily activities can develop metatarsalgia, and I can tell you that I have that. And I always say, after I go through all of these, we have to not forget the vain woman. And what do I mean by the vain woman? Is the women who wear those high heel shoes, and the men who support them and applaud them. So the women in the group do not wear high heel shoes, okay? Because almost everything I'm going to show you today, you can get from metatarsalgia. And this is, what we don't have to, this is just a repeat of what we're going to do is, we're going to talk about soft tissue disorders, osseous disorders, and basically cover all these topics. Okay. So when we look at causes of metatarsalgia, it basically has to do with localized pressure in that area. And it's not surprising, when we walk, we first touch heel, right? And then we go forward and we put our weight, the weight gets distributed from the heel to the metatarsal heads, usually the first and the fifth metatarsal heads. But any shift in biomechanics, for one reason or another, will shift the weight to the second and third metatarsals, and you'll get pain in that area. So again, I mentioned Morton's foot, which I'm keeping you in suspense about what it is. Sometimes you have developmentally prominent or enlarged metatarsal heads. If you have a high arch, if you have high extensor, tight toe extensors, you could see that with increased extension, you're going to have more pressure in that area. Tight Achilles is going to pull on the plantar fascia, is going to also produce high arch, also more pressure in that area. So there are many reasons for it. And here is, for example, if you look at foot contact, and I mentioned to you, in normal, we usually put at heel strike, we put our weight at the heel, and then we lift off, and when we descend downward, we're putting our weight on the first and the fifth metatarsals. But if we have, for example, flat foot deformity, something's happening, I'm not going to do it. So basically the weight gets distributed into that area right here. And this is supposed to stay there. Something is happening with my animation on that map, I'm not sure what. So anyway, before I go further, I'm just going to ask you, and many of you may not know that, although actually you're coming from France, many of you, so you should know whose foot mold this is. Anyone can guess, and I'll give you, and then,
Wizard of Oz.
Exactly, Wizard of Oz, right. So this is an enlargement, and the reason why you as the French people should know is because you gave this sculpture as a present to the American people, right? So this is the Statue of Liberty, and the Statue of Liberty has a Morton's foot. And what is a Morton's foot? A Morton's foot is a long second metatarsal, and I'll show you an example. So this is my only joke. I'm not very funny, so this is my only joke for the lecture. So if the lady could walk, she would complain of what? So she could complain of metatarsalgia, and why? Because she ain't a lady, because she's a woman, for the men in the group, because she's not made of stone, or because she has a Morton's foot. And the answer is because she has a Morton's foot. And again, something crazy with my animation. So what is a Morton's foot? As I said, it's basically a long second, usually long second metatarsal, so as a result you have a long second toe, and as a result you get distribution of the weight from the first metatarsal to the second metatarsal. And the reason why you saw it in this sculpture, because this was supposed to be a beautiful foot. It's called the Greek foot, and it was localized in the Greek sculpture. So that's why many sculptures have this long second metatarsal. In reality, it's really a very Neanderthal foot, and it's used for grasping. So if you're running away from, I don't know, in the jungle, it's going to help you climb. Anyway, less than 50% of people have a long second metatarsal or a long second toe, as we see here. But in people who have metatarsalgia, people who have pain in that area, more than 80% of them have a second long toe. And basically it's due to a shift in the weight or the stress distribution to that longer second metatarsal, and that predisposes to many of the things that we're going to be talking about. And here is again an example. Now, so this patient has hindfoot valgus with hallux valgus, and with hallux valgus you get rotation of that first metatarsal, so in reality, and it gets displaced medially, so in reality it acts like a short first metatarsal. Well, if this is a short first metatarsal, this by result is going to be a long second metatarsal. So the problem could also be in the first, could be a short first metatarsal, as we see here. Okay. And here is an example of a non-Morton's foot. So if I draw an arc like that, the first and the second metatarsal are almost at the same level, while here we see a much longer second metatarsal. Okay. So these are 3 different patients with Morton's foot, and you could see examples. I already mentioned to you that hallux valgus, by the pronation of the first metatarsal, can produce a functional long second metatarsal, as we see here. But if you have severe osteoarthrosis, as we see here, you get shortening of the first ray, and you get secondary long second ray. And this is a patient with crossover toes, again associated with this finding. And this is another patient with this is a 45-year-old woman with Morton's foot, severe hallux rigidus, right? We see osteoarthrosis in this area. And we also see, and I know it is subtle, but she actually has a second metatarsal fracture. And it is very subtle, but I have the MRI, and here it is. There is the second metatarsal fracture. So it is subtle. You can barely see it here, but on the MR, obviously she has a second metatarsal with a Morton's foot. So it works. And Morton's foot can be iatrogenic, right? If you have first metatarsal osteotomy for hallux rigidus, usually hallux valgus, you can also get a secondary long second metatarsal. And this 58-year-old also had a stress fracture status post hallux valgus repair, and we have the MRI, and there is the fracture. Very hard to see it on the X-ray. Okay. So other things when we talk about stress fractures as a cause for metatarsalgia, we usually talk about it in the distal aspect of the metatarsal. Just remember, sometimes you can have stress fractures at the base, usually at the second, more in patients who spend a lot of time jumping, such as ballet dancers or basketball players. So talking about stress fractures, fracture. Typically, it is in the second and the third distal metatarsals. It can have focal, usually it's focal cortical thickening. Extensive, one of the things you have to remember, you get extensive marrow and soft tissue edema. And I say that because sometimes people don't realize it, and when they're, I guess with experience you learn it, but if you see a lot of edema in the whole second metatarsal and the fracture is distal, you can be confused with that. So bottom line is, don't be confused with that. This is common. You can have a lot of marrow edema with a stress fracture. You can also have a lot of soft tissue edema. And as we see here, there is the fracture right here, a lot of marrow edema, all the way almost to the base, a lot of soft tissue edema associated with it. And I told you about the fracture at the base. And if we don't see a fracture line, and this is going to Dr. Gormazi's lecture, if you don't see a fracture line, what do you call it? Stress reaction? Personally, I find that the terminology of stress reaction when it comes to the foot is not, I think it's dangerous, so it can lead to issues. And the reason for that is because really MRI, the resolution of MRI to see cortical breaks is not as good as, let's say, CT. And there may be a fracture there that you're just not picking up. So if I see what, as Dr. Gormazi was saying, if you see abnormal signal on the fluid-sensitive images and you don't see a fracture line, I would still worry about a fracture, and I would say this is either a stress fracture, an occult stress fracture, repeat radiographs, or do a CT, or I would call it a pending fracture. I actually, when it comes to the foot, I stay away from the terminology of stress reaction. And why do I stay from the terminology of stress reaction? Is because a lot of patients just have normal, and I'm sure you've seen it, this marked cortical thickening, right? And we see it all the time. And that is actually stress reaction. You're walking a little funny and you go causing cortical thickening along the metatarsals. So that is stress reaction. Well, usually that's not symptomatic. I don't even mention it in my report. So that's why for the foot, I don't like that terminology. But nevertheless, if you wanted to think about stress reaction in the foot, you think about abnormal abnormal T2 or abnormal fluid-sensitive images and a relatively normal T1. So that would be the definition. That would be the ACR definition. And you can also think about it as a spectrum of disease. Initially, you stress your, we know that with marathon runners, we know it with ballet dancers. If you image someone right after they run, you may see marrow edema in their bones, and they're usually completely asymptomatic. But if they continue running and running and running, they may start, you'll see the same MR images, but they'll start having pain. And eventually they can develop a fracture. So it is a spectrum of disease if you want to look at it like that. And basically, I don't need to spend too much on this, but just to emphasize, almost everything is the same between stress fracture and stress reaction, except the signal abnormality. So there's barely any signal abnormality on the T1 with stress reaction and a lot of abnormalities on T1 with a fracture. But as you see here, stress reaction has no fracture line, but stress fracture may or may not have a fracture line on MRI. The same thing, stress reaction, no cortical break, MRI may or may not have a cortical break when it comes to fractures. So just keep that in mind, that just because you don't see a fracture line doesn't mean that patient does not have a fracture. And here is an example, and what do you think this is, stress reaction or stress fracture? So basically, I see fluid edema in the second metatarsal, right? Here is edema, and this is on the fluid-sensitive images, but on the T1, I don't see much. So if I want to call something a stress reaction, I'll call this a stress reaction. I have to admit that I am curious about other people. I haven't seen many of those type of cases of stress reaction with a relatively normal T1. Okay, so moving on to more bony abnormalities, we're going to talk about Freiberg's disease, so Freiberg infraction and subchondral fracture. And basically, Freiberg's infraction is utilized for young people, for adolescents, and the subchondral fracture, we usually use that terminology for adults. It's usually in the second metatarsal, but it could be in the third. And they used to believe that it's AVN, but now we realize it probably is trauma-related and a fracture. And as I said here, puberty, we call it Freiberg's, and in adults, we call it the subchondral fracture. There is tenuous circulation in that area, so with repetitive trauma, you can get microfractures. And again, what are predisposing factors? Could be Morton's foot, could be high heels, just a reminder for the women not to wear high heels. Metatarsal head osteotomies can predispose to that. Fractures, shaft fractures here can predispose to subchondral fractures. In reality, I actually think that if you have fractures elsewhere and you're not bearing enough weight, you're going to develop a focal area of osteopenia, and then you're susceptible to subchondral fractures. The patients have pain, limitation of motion, and the treatment initially is footwear modification, pads, short leg walking cast if it is starting to fragment, and there are some articles in the literature about osteochondral grafts. We don't really do them at our institution, but people talk about them. Now, look at this. This was a 19-year-old asymptomatic patient, and look at the marked flattening and fragmentation. And actually forget why he came. He came for pain in the foot, but I think he had midfoot pain, and he was completely asymptomatic here. Now, he's also 19 years old, but you can have it and be relatively asymptomatic. And when we talked about metatarsalgia, I talked about increased stress here. Well, it's the same thing with the subchondral fractures. You get increased stress here. Because we hold when we walk, we hyperextend in this area, the infraction fractures are usually along the dorsal aspect of the second metatarsal head. So usually you get the fractures here, and eventually when it progresses, it could affect also the plantar aspect. And you get on x-rays, you get flattening, you get sclerosis, fragmentation. Eventually you can develop osteoarthrosis. And MRI, you get similar findings to the x-rays, where you get the subchondral fracture line, the sclerosis, the marrow edema, etc., fragmentation. Now you have to remember that sometimes, actually in a relatively significant percent of people, the metatarsal heads are a little bit flattened. I don't know if you've noticed it, but it does not have to always be pathologic, and I'll show you a few examples. So here we have a patient, 64-year-old, with iatrogenic Morton foot, right? Why iatrogenic Morton foot? Because he had an osteotomy here, right? So he has shortening of the first metatarsal, and he developed a subchondral fracture right here. Now, this is a 28-year-old woman with pain, 4-foot pain, and when you look at her metatarsal heads, you kind of say, well, maybe this is a little flattened, maybe a little bit sclerotic. I'm not sure if this is a real finding. I make it bigger, and here it is, a little bit of sclerosis here, but really very subtle. I would easily miss that. And when we do the MR, we could see that she indeed has a subchondral fracture. Now look at this person. Remember I said to you they could be flat. The heads could be a little flat. So here you have a flat head right here. Is this a subchondral fracture, or is this normal? And the answer in this particular case is it's completely normal. Right? Here it's flat, and it's completely normal. So the truth is sometimes I cannot tell. If I don't see fragmentation, if I don't see a lot of sclerosis, I'm not sure. But I may suggest that. I may say this patient has a flattened metatarsal head, possibility of subchondral fracture should be considered. And I'll show you this case. This case has flattening here. If anything, I think they're both bad, right? They're both kind of flattened, maybe even sclerosis. So does she have subchondral fracture in both? And it turns out only on the first. Right? And the second is completely normal. So it's a little tricky. Moving on to Morton's neuroma, actually, Dr. Adler spoke about it, and basically, I won't belabor it. I'll just say to you that on MR, and you could see it beautifully on ultrasound, but on MR, the the way to see it best is on the T1 weighted sequences. Not on the fluid weighted sequences, but on the T1. As you see here, it should be bell-shaped. It extends to the plantar aspect. No point in giving contrast because it may or may not enhance. So it really, contrast doesn't help you. If it enhances, fine, but if it does not enhance, you don't know, you're not better off. So you don't need to give contrast. You have to remember that it can be often multiple and it's often asymptomatic. Actually, when my fellows, if I look at a report of a fellow and they say no Morton's neuroma, I know they missed one because they're almost always there, and many times they're asymptomatic. So here is the same patient, right? You see it beautifully on the T1. You don't see it at all on the fluid-sensitive images. You happen to see it on the post-contrast, but as you see, not all of it enhances, and sometimes it does not enhance at all. So really your T1, because it's being highlighted by fat, is your best sequence to look at it, and the short axis sequences are also the best way to see it. When you think about Morton's neuroma, a few other things you need to look for is intermetatarsal bursas are often associated with it. Sometimes plantar plate injuries are associated with it, and I'll talk about that in a second. Now, this is another patient, again, a dumbbell-shaped appearance. In the web space, extending marker is right here, but this is a little bit suspicious, right? It's extending too far to the skin. So you have to remember your differential diagnosis, especially if it looks big, and this is a recurrent extraskeletal chondroma. Almost all the time when you see obliteration of the web space and extension of the plantar aspect with a soft tissue mass, it's almost always Morton's neuroma. But sometimes you do have a differential. If it extends too far out, too close to the skin, think about the possibility of other lesions. Could be gout, could be amyloidosis, PVNS, and in this particular case it happened to be a tumor. Could be an adventitial bursa. Sometimes adventitial bursas are complex, and I already mentioned PVNS and gout. So just to emphasize, Morton's neuroma usually does not extend far in toward the subcutaneous tissues. Now this is another patient. We see this mass here, very well circumscribed, and this is really an adventitial bursa. It's very common to have adventitial bursas at the ball of the foot. Keep that in mind. And they don't have to be fluid filled. Most of the time in the foot they're susceptible to so much trauma that they are scarred down and you don't see much fluid. And the truth is, sometimes you don't know. Is it an adventitial bursa or is it something more worrisome? And you just need to, kind of weigh the finding, and sometimes you have no choice and you may need a biopsy. This is another patient. Looks like a Morton's neuroma, but it's extending also dorsally quite a lot. And this turned out to be, here it is, turned out to be what? So what are all this stuff here, right? We have these erosions here, right, with overhanging edges, more of these structures here. This turned out to be gout. Okay. Moving on to plantar plate injury. The plantar plate is a strong fibrocartilaginous structure which stabilizes the metatarsalgia joint. Here it is. There is the plantar plate. Has weak insertion to the metatarsal, strong insertion to the proximal phalanx, but usually tears at the proximal phalanx. And this is a common cause for metatarsalgia. You need to pay attention to it because it's not so common for you to get a history, rule out plantar plate injury. More commonly, they'll just say, rule out stress fracture. And they won't necessarily tell you that. So you need to pay attention to it. And this is the plantar plate. Notice the proximity of the flexor tendons right next to it. You have here the extensor hood. I won't spend too much time about the anatomy here, but the plantar plate is kind of like a hammock, like a C-shaped structure that actually gives support to metatarsal phalangeal joint. So here is normal, okay? So we start with it, you see it here. These are the tendons sitting right next to it, and I'm going to show you sequential images. We are at, let me go back. So we are at the level of the metatarsal heads. You see that C-shaped structure, and you're moving forward. You're moving more distally, right? You're coming into the joint, and you're starting to see almost the insertions. Here are the insertions, and usually you have an area that has increased signal at the center of the plantar plate at the insertion. It's probably fluid-filled recesses. Sometimes you have cartilage undercutting in that area. But this is fairly typical, normal plantar plate. And on the sagittal images, we see it beautifully. Here it is, here is the flexor tendon here, and here is the plantar plate. As I said, you can have, can you see my, you can have a little bit of a recess right here, sometimes cartilage undercutting. That's normal. If it measures more than 2 millimeters, I worry about it. I worry about the gap. So MRI of plantar plate injury, what do we see? Many times we see retraction of the plantar plate. We may see heterogeneity. It can be completely disrupted. When it tears, it usually tears laterally more than medially, and it usually tears distally more than proximally. You can have one clue to it is whenever I see tenosynovitis of the flexor tendons, I worry about plantar plate injury. At least in my experience, they're very commonly associated with each other. You can see, because that is actually, remember I showed you how the tendon is so close to the plantar plate. You don't see a distinction. Now this is routine MR. We don't do microcoils. So in routine MR, you don't see the difference between the tendon and the plantar plate that well. They kind of adhere to each other. When you see the difference between them, that usually means you have an inflammatory process there, you have tenosynovitis. Almost always, you'll have a plantar plate injury. Okay, so I think we covered all of that. The tendon can be displaced, maybe asymmetrical. And another thing to remember is you see plantar plate injury, you almost always will have a Morton's neuroma associated with it. You may have other things like tendon disease, I already mentioned, synovitis, sometimes ligament tear. So a lot of these things often are coexist. And there's also coexistence of bony disease because that plantar plate stabilizes the area. You can get toe deformities, dorsal displacement of the proximal phalanx. We sometimes see marrow edema related to stress. And this is easy. So we have a nice plantar plate here. You don't see much distance between the tendon and the plantar plate. This is the third. Same thing here, the fourth. But look at the second. So we have a lot of soft tissue changes. We have synovitis here. We have asymmetric position of a very well seen tendon, right? We see the tendon very well. We see that there is lack of the plantar plate here. And we also see all these soft tissue scarring here, which some people will call plantar plate fibrosis, but in reality, as far as I'm concerned, it's not very different than Morton's neuroma. So you're seeing here concomitant finding associated with plantar plate injury. And here on the fluid-sensitive images, you are actually seeing tenosynovitis as well as a little bit of partial tearing of the tendon, and you're also seeing ligamentous injuries. So as I'm just going to reiterate, you often see the findings, multiple findings. Another patient, similar thing. You're seeing a nice plantar plate here. Here is the insertion of the plantar plate. I told you that you can have some bright signal in the center as it inserts. This one looks kind of funny. First of all, it's very well defined here, but because it is retracted, the tendon is away from it. The tendon is very well defined. It has tenosynovitis, and at this level here, I don't see any insertion. I see a lot of edema here, and I see asymmetric position of the tendon. So this is plantar plate tear, and the same here, we see the same finding, and we're seeing some fluid in the tendon sheath. Now, I showed you the sagittal before, normal sagittal here, well-seen plantar plate. Here, the plantar plate is markedly retracted, and we see here subluxation of the proximal phalanx and widening of the joint, synovitis at this level. All of these findings are associated with plantar plate. Now, I said before, we actually do routine MR for them. We should do, it would have been nice to do dedicated study for this area, but we don't do it because many times we don't get the history. But as you can see, you could still tell. You don't have to do microcoil to see these findings. And here it is, another retracted plantar plate, another very well-defined tendon, marrow edema, even flattening of that second metatarsal head. And I guess I am a little bit in love with that entity because I'm showing you more and more. Here is associated Morton's neuroma, partial tear of the plantar plate, and partial tearing of the flexor digitorum tendon to that area. And maybe we could skip just to show you marrow edema associated with it. Another one. Oh, this was interesting because this one, partial tearing here, displacement of the tendon, Morton's neuroma associated with it. This patient had accessory collateral ligament injury associated with it. They treated, here you see it. They treated this patient for the plantar plate, and guess what? A few months later, she developed a subchondral fracture. So she had abnormal biomechanics, walking wrong, osteopenia, and finally a subchondral fracture. And this is my only claim to fame as far as ultrasound. This was given to me by Ron Adler. Here is a very nice plantar plate, and here is a torn, retracted plantar plate. Okay. Okay, so moving on, anybody sees the pathology here? We finished with plantar plate. 76-year-old woman post-second hamate repair. What's missing? So we see plantar plate, tendon, plantar plate, tendon, plantar plate, no tendon. So they basically, when they did the hamate repair, they actually mistakenly dissected and caused resection of the flexor digitorum longus. And here it is, and it's retracted and curled upon itself at this level. So just something, not common finding, something to look at, to keep in mind. And I'm going to finish with this. 41-year-old woman with painful fifth metatarsal mass, and we see this marked soft tissue density here. And this is a talar bunion. And a talar bunion is basically just an adventitial bursa, very common in the fifth metatarsal. You could see why it was called a talar bunion, because talars, I guess years ago, used to sit on the floor and sew. Before our time, we don't sew anymore, right? We don't do that anymore. And just to save some time, I won't go through that, but there are all kinds of variations in the anatomy of the fifth metatarsal that can predispose you. But in reality, remember I told you about adventitial bursas. In reality, when you look at your MRIs, very commonly you'll see obliteration of the fat and kind of like a soft tissue mass adjacent to the fifth metatarsal head, and a lot of times adjacent to the first metatarsal head. So you get those adventitial bursas on both sides of the foot. And here is an example of it. There is, and you can see that it doesn't have to be all fluid filled. Part of it is fluid filled, and part of it isn't. And this is another one, a giant one, and here it is, and here it is. Very common location. I admit most of the time that I see it, I just say adventitial bursa, and I don't really worry about a tumor. So in summary, I tried to show you various causes for metatarsalgia, and I tried to tell you that they can be interrelated to each other, they can be concomitant with each other, very commonly associated with Morton's foot. You can have, as far as the osseous findings, you can have stress reactions, stress fracture, Freibergs, and subchondral, and then here you can have Morton's neuroma, plantar plate, and ligament and tendon injuries. And the most important lesson from this lecture? Exactly. No high heels. Good.